Thank you for that introduction. Again, I am Kristen Wall. I work at Emory University with the Rwanda-Zambia HIV Research Group. And the title of my talk really, it's building very well off the previous speaker. The title really captures the research question we were asking: does hormonal contraception increase HIV acquisition risk among serodiscordant couples, among serodiscordant women in Zambia? So we have no conflicts of interest. So by way of very brief background, most people know hormonal contraception decreases unintended pregnancy, and this is prong 2 of prevention of mother-to-child transmission for women who are HIV positive. And hormonal contraceptive methods are widely used in areas of the world where HIV prevalence is simultaneously very high. So for example, in Zambia, where this study was conducted, the HIV prevalence is 14%. And I'm showing here the distribution of hormonal contraceptive methods used among married women. So 11% of women are using oral contraceptive pills or OCPs, 9% for injectables, and the implant use is currently much lower. So as Dr. Morrison mentioned, the existing evidence on this issue is very conflicting, and in 2012, the WHO held a technical meeting to review all of the evidence to date, and we'll get an update on that information from our next speaker. But during this meeting, they reviewed this evidence and recommended a medical eligibility criteria for hormonal contraceptive methods of 1, which means no increased risk. However, they did emphasize dual method use, so promoting condoms, for women that were at high risk of HIV and using progestogen-only injectables. So then in 2013, Chelsea Polis and this group published this wonderful article in AIDS that basically reviewed all of the analytical and methodological challenges that some of the previous studies had, and they came up with a lot of recommendations about how to address those challenges. And so we were very cognizant of these recommendations when we did our analyses. So in our analysis group, we have serodiscordant couples in which the man is positive and the female is negative at baseline. These couples were identified from couples voluntary HIV counseling and testing centers in Lusaka, Zambia, between 1994 and 2012. Couples had to be over 16 years of age. The male partner could not be on antiretroviral treatment. And we followed our couples at 3 monthly intervals. And during those intervals, contraceptive methods were provided to the women, and all of the HIV negative partners were retested. So just by way of sort of categorizing the types of methods in this study, hormonal methods include implant, which is the Norplant or Jadel, DMPA injectables, and combined oral contraceptive pills. Our non-hormonal groups included women who were using no methods, condoms primarily for HIV prevention, the copper intrauterine device or IUD, or permanent methods, which included hysterectomy, tubal ligation, and vasectomy, I should mention. So we had 2 primary outcomes of interest. The first was time to any HIV seroconversion, and that's inclusive of conversions that were genetically linked or unlinked to the study partner. And then our second outcome of interest was just looking at those linked infections. So we ran multivariate Cox models. The potential effect measure modifiers that we proposed to look at a priori included genital ulceration and inflammation of both the male and female partners, the baseline viral load of the HIV positive male partner, the couple's fertility intentions, and age. And we also conducted many sensitivity analyses, including we looked at different ways to categorize our exposure and control groups. We looked at cumulative method exposure. We did a sensitivity analysis around potential misclassification of unprotected sex. And we also assessed for the potential of time-dependent confounding using marginal structural models. So in our analysis group, we have almost 1,400 serodiscordant couples. 82% of these couples did not experience a seroconversion during follow-up, and 18% did. And of the couples that did seroconvert, 82% of those seroconversions were linked. So the majority of the seroconversions were genetically linked to the study partner. And obviously, I don't have time to present all of the baseline demographic data, but I did just want to show this. This is the distribution of contraceptive methods that were used at baseline. So most women were using no method or condoms. Between 10 and 11% were using OCPs and injectables, and very few women were using implant, IUD, or permanent methods. And these distributions did not differ depending on whether the woman experienced a seroconversion during follow-up. So the next few slides I'm going to show you are the seroincidence rates that we observed stratified by the type of method that women were using. So just using the women who were using no method or condoms as the reference group, these women experienced 150 infections for a seroincidence rate of about 8.4 per 100 couple years. And women reporting or using OCPs experienced 49 infections, and this is an increased seroincidence rate above the reference of 11 per 100 couple years, and it is marginally statistically significant with a p-value of 0.06. Women who were using injectables experienced 42 seroconversions over the study period for also an increased seroincidence rate of 10.7. This was not statistically significant. And finally, women using implants experienced 9 seroconversions for a decreased seroincidence rate of 7.3 per 100 person years. So these are the results of our multivariate model looking at time to any HIV infection. So again, that's inclusive of the genetically linked and unlinked infections. And as you can see here, we did not see in multivariate models any increased risk for women using hormonal methods. And this model is controlling for women's age, literacy, whether sperm was present on a wet prep during the interval, and time-varying genital ulceration and genital inflammation of the female partner. And our findings remained basically the same when we controlled for pregnancy or didn't, and controlled for fertility intentions. And then just to kind of summarize the rest of our results, when we ran our multivariate model of just the genetically linked infections, we also did not see any significant increase in risk for women using hormonal contraceptive methods. And this model was controlling for what I showed you on the last slide and baseline pregnancy, self-reported unprotected sex between the couple, and this was time varying, genital ulceration and inflammation of the male partner, also time varying, and the baseline viral load of the HIV positive male partner. And additionally, all of our sensitivity analyses, including the marginal structural models, did not indicate any significant increase in risk. So we wanted to sort of explore, why did we see these slightly increased rates for women using OCPs and injectables, though they weren't statistically significant? And maybe this could shed some light on why some other studies have seen some of these associations. So we looked at various measures of unprotected sex by the type of method being used. And we found that women who were using OCPs experienced significantly more pregnancies, as you might expect, had self-reported unprotected sex more often during an interval, and had intervals with sperm present on a wet prep more often than women using non-hormonal methods. Women using injectables self-reported more unprotected sex, significantly more unprotected sex than women using non-hormonal methods. And finally, women using implants experienced no incident pregnancies, as you might expect, and self-reported fewer unprotected sex acts and had sperm on a wet prep during fewer intervals than women who were using non-hormonal methods. And we also wanted to explore the effect of pregnancy status. So we looked at measures of unprotected sex by whether a woman was currently pregnant or not. And we found, very interestingly and surprisingly to us, that when a woman was pregnant, she was more likely to self-report a higher number of unprotected sex acts, any unprotected sex more often, and have sperm on a wet prep during more intervals than women who were not pregnant. So in conclusion, just to restate the findings, we found no association between hormonal contraception and HIV acquisition risk in these Zambian women in discordant couples after controlling for multiple measures of unprotected sex and looking at for effect measure modification and conducting sensitivity analyses. And we recommend that reinforced condom counseling is needed based on these findings during oral contraceptive pill use, injectable use, and during pregnancy. And finally, these findings obviously are adding to a very controversial literature and evidence base that is currently highly variable and will be important when considering changes to the MEC categories. So I just want to acknowledge all of my wonderful contributors at the Rwanda-Zambia HIV Research Group. I'm really presenting this data on behalf of a lot of people and a lot of time and work. The Zambian Ministry of Health and District Health Management Team, and of course all of the study participants and the clinic staff. And of course, I want to acknowledge all of our funders without whom this wouldn't be possible, and to especially note the support of the International AIDS Vaccine Initiative, or IAVI. And I'll take any questions. Sure.
Hi, Jill Gay, Wetworks Association. My question is twofold. One is, why did the men not get on treatment? And did you, since they weren't on treatment, do you have any sense of what their viral load would be like and how that might have affected results?
So I should say men do initiate treatment, and when they do, that's one of the points where we censor them.
And what about the viral load?
Well, actually, I don't know the effect, their viral loads over time. We only have a baseline viral load in this data. In terms of, so we actually do have time varying viral load over a very short period of time. So when we, and same for fertility intentions, I mentioned that we did control for fertility intentions in some models. So when we control for those, because we have them for a shorter period of time, we lose a lot of seroconversions. But so when you put time varying viral load in or fertility intentions in, the results still remain non-significant.
So there's a question in the back.
Thank you very much for your very informative presentation. My question is, in your phase regression model, you combined as a reference those who used condoms and those who used neither of the method. And you were comparing, of course, with oral contraception. So I was wondering, probably, did you do any other analysis to compare those who used none of the contraception method versus the rest of contraception methods, and then later probably a condom as the baseline so that you can compare for other hormonal contraception to come up with those important results you have?
Sure, that's a great question. So I briefly mentioned this and I didn't go into it too much. In the sensitivity analyses that we did, we looked at different ways to categorize our exposure groups and our control groups. So we did use a control group that was women who were using no methods or condoms alone for HIV prevention. We compared each hormonal method to these groups individually. We grouped all of the hormonal methods and compared them. So we tried all of these different categorizations, and this is sort of based on recommendations in the Polis article I mentioned, and still our results remained basically what you see here.
One more question. Can I have one question? Raina Ficharova from Brigham and Women's Hospital, Boston, Massachusetts. Thank you for this very important study. My question is, how did you assess inflammation in both partners, and did you observe any differences among the groups on different hormonal contraceptives versus?
So inflammation was either self-reported by the patient or treated or diagnosed by the clinician, and included inflammation on a physical exam, discharge, bacterial vaginosis, chlamydia, gonorrhea, and I'm missing one, candida. And we did not see any effect measure modification by GUI status.
Great.
Thanks
Thanks very much.
Thank you.